Okay, so thank you, Petra, for the kind introduction. Thank Canon for the invitation, the opportunity to be here. And thank you all for being here. So let's just play this. Yeah, it should be running. Okay, so I will be talking together with Professor Monique. We will be talking about heart today. And on Wednesday, we will be talking about monochorionic twins, because those are the two things that I like most, heart and monochorionic twins. And the heart is always challenging for all of us, for me especially. And I was lucky enough to have great professors in fetal heart. And I think that every time that we have the opportunity to talk about heart, it's important, mainly because of this. You may know the data here. That's this data is from the EuroCat. This is European data. You can see that the prevalence of cardiac congenital, between the congenital abnormalities, fetal heart is by far the most prevalent. This is data from 2021, released recently. And this is the data on the prenatal diagnosis from 2019. From the same group, from the same EuroCat. And if you compare detection rate at any gestational age of major cardiac abnormalities compared to other major structural abnormalities, even though along the years we have improved significantly our detection rate of, for example, transposition of great arteries from 46 to 64%, is still one of the least detected abnormalities. You can follow many protocols. There are many protocols that you can use to set up in your clinic. You have ISUOG protocols. Well, every society has one. We published recently, together with the Perinatal Medicine Foundation, comprehensive protocol on first trimester scanning. And you have a very basic, well, you can see the recommended and the suggested here. It's all the axes that you should see and the things that you should be looking for. You can have, I think it's a free open access paper. You can have a look and you can see if you like that, or you can use any other one. So you can use any preset, any guidelines that you feel like using to set up your clinic in scanning in the first trimester. Of course, we will have challenges and we will have advantages. And that's what I'm going to talk with you a little bit. And then we'll move on to the hands-on. I just saw someone here that puts me very nervous now. I just saw Professor Julene there. So I just now I have a lot of pressure. I need to be very proper when I'm talking now. When I mentioned that I was lucky enough to have great professors in my life in fetal heart, she was one of them. Okay, so I'm very happy that you're here. Thank you. Thank you very much. So you have always challenges in setting up your clinical setting. And actually, that's one of the main challenges. If you look here, you can see that scanning depends on several factors. And one of the most important factors that we'll look for is the expertise of the operator. Unfortunately, until artificial intelligence takes over, it depends, most of the things we do depends on our expertise. The more experienced you are, more likely you are to see minor changes, and I try to look into that. And then another thing that is very important is the time that we have allocated for the scan, and I always stress that up. Nowadays we are pushed and forced to do numbers for some reason. We need to do a lot of scans, and they try to give us a little slot of time. Especially for first trimester. We need to remind them that nowadays the scanning first trimester is much more than the simple measurement of the nuclear translucency. And we see a lot of things, and if we want to include a lot of things, we need more time. Because the second challenge that we have, the third, sorry, is the objective that we have for our scan. And the objectives we have for our scan will for sure affect the time we have that. Then we can have new technologies that may help. We can have a very simple example. If you're scanning in a 20-year-old machine, you are more likely to have more difficulty. It's not impossible, but it's more difficult to see some structure. The new machines allow you for easy visualization of the fetal structure for heart or for any other one. And you can have markers that can help you, and we're going to just very briefly discuss that. So those are the mostly the clinical challenges, the challenge that we have in our clinical settings. But if you think of that, all the challenges that I put here, they are challenges that we find in any gestational age. They are not specific for first trimester. They can happen at second and can happen at third trimester. Another set of challenge that we have for heart specifically in the first trimester is related to the time we have for evolution of problem. It's not uncommon that you see a completely normal heart, as you see there in the video there, in the first trimester, and comes to later on, it becomes a completely normal heart, abnormal heart. That's because some of the abnormalities that we will see, they depend on time to show up. They depend on an evolution. So they might look, the heart may look normal in the first trimester, but they will look abnormal later on. But it is also a challenge for the second trimester because there are also abnormalities that the heart looks normal in the second trimester and they show up later on. Another set sort of specific for the first trimester is the size. In comparison to a second trimester, I will go for the next one because it's easier to see. In comparison to a second trimester heart, the details that we will see in the heart in first trimester, you can see sort of less. But then, even though you can see this comparison, it is also true that a second trimester heart you may see a little bit less than in the third trimester heart. So it is a challenge, but it's not an impossibility. If you look at the challenge, what is the advantage of looking at the heart in the first trimester? The main advantage is that it's a window of opportunity. And as I told, because cardiac abnormality is one of the least detected, the most we see or the more we look at the heart, more likely we are to detect abnormalities, so we may increase our detection rates. So we already perform a scan in the first trimester. Most of the patients do, for screening for aneuploidy, screening for preeclampsia, and why not screen for cardiac abnormalities. You can use this window of opportunity and you can use the markers that we all know to pre-select which are the patients with a higher risk for cardiac abnormalities by looking at markers that we all know, nuchal-translucency, ductus venosus A-wave, and tricuspid regurgitation. You can have a screening test. I will focus here just because of the time at the bottom line here. You can have a screening test that detects about nearly 50% of all the major cardiac abnormalities for a 4% false positive rate, which means that your cardiologist will see 4% of your population and you detect about 50% of the major cardiac abnormalities. If you use the NT above the 99th centile. If your cardiologists have a little bit more time and are able to see 8% of your population, you can use the NT above the 95th centile, and then you increase your detection rate to about 55%. So you can use the markers that we already know to pre-select. It's one way of looking at the heart in the first trimester. From the data from the group of Italy, from Paolo Volpi, you see, showed us that if we look at the four-chamber view, and if you do tricuspid, you already know how to look at the four-chamber view, normality of four-chamber view, your detection rate increased to 75%, which is a great model of screening, not detecting, screening the heart in the first trimester. Okay, but if you are to look at the heart, how much of the heart can we see in the first trimester, and how often can we see that? Yeah, we know that we can show you nice images of the first trimester heart. They will look good, but how often can we see those things in the baby? So we went to look into that, and we see we have now, I still didn't publish that, but we have now 3,000 unselected babies in the first trimester. And we try to look following this protocol. So we look at the four-chamber view there, where you see size, position, proportion of the ventricles, and the offsetting of the AV valves, as you can see there very clearly, and the cardiac crux. And then we move to the left outflow tract, so you can see the clear connection between the aorta and the left ventricle, which is the important part, a clear connection between them. The crossover of the great arteries, and then we run to the right outflow tract where you need to see very clearly the connection, but mainly the branching of the pulmonary artery, which is the one that defines that you actually are the pulmonary artery. That one is the pulmonary artery. And the three vessels view, where you can actually see the three vessels, because most of the time that we see, well, we say that this is a three vessel, we saw two of them. So we'll try to look into that. And we went, so as I told you, went to look to an unselected routine first trimester population. You have 3,000 cases now, and this is how often you see satisfactory all these sections. In about 80% of the times, we are able to see the 4-chamber view of the heart satisfactory, that satisfy all the criteria that I put. In about 70% of the time, we are, you can see the aorta. In about 65% of the time, the pulmonary artery. In about 88% of the time, you can see the three vessels view clearly with a superior vena cava, aorta, and pulmonary artery. And most importantly, I think, is this graph here that shows how often we can see the whole thing in one single baby. And we can see that in about 81% of the time. That using B mode and color Doppler, high definition color Doppler. Those are the things, yeah? But then you can ask me, how can we improve that? Can new technologies help us to look at the heart a little bit better or look, see more of the heart? And we went to study this Doppler, it's called the SMI, and I will show you the data in a minute. In addition to B mode and high definition Doppler, we look into the SMI. We published a couple of years ago together with a group of Evelina, John Simpson, and it showed us, I will just go quickly because I want to show you the other data I have. It just showed that SMI in gray here increases your visibility, satisfactory visibility of the different structures. 4-chamber view, outflow tracts here all together, left and right, and three-vessel view from 60 to 83%, from 60 to 85%, from 65 to 90%, 95%. So SMI help us. And then we went to continue looking, so the same data that I showed you before with only the B mode and color Doppler. And SMI helps you to assess the heart because it makes sometimes very easy for you to see. So it's a Doppler, and although it's a Doppler, we don't really want to look into the Doppler itself. We want to look into the inverted image that it gives, and because it defines very well flow and also the movement, and remove the movement, it leaves you only the flow. So the effect that you have is that the structure of the heart is well seen. But you need to look at it in an inversion mode. That's how you see it. You see just this negative image. But it helps you to see very clearly the connection of the aorta with the left ventricle from 70 to 94%. And the branching of the pulmonary artery becomes much more clear from 65 to 91%. And the three vessel view, where you actually see the third vessel, which is the superior vena cava, from 88 to 98%. And also helps you to see all these structures in one single baby from 81 to 96%. So we are able to look at the heart. We are able to see the structures that we should see. You can either use or not new technologies, but if you use new technologies, you are likely to be able to see a little bit more. And then the next question is, can we detect cardiac abnormalities in the first trimester? And you all answer yes. And this data from the group of Professor Nikolaidis show exactly that. That if you look here, the last line here, you see that the total detection of major cardiac abnormalities in first trimester is about 50%. But then you have a vast different detection rate depending on what abnormality you see. And you can actually, although it looks a little bit lost there, you can actually classify those in three, yeah? So the ones that we need to look at the 4-chamber view to detect, they are the most likely for us to detect. The ones that we need to look at the outflow tracts, you are able to detect, but you are less likely. And of course, as I said before, the one that we need time for, you can see the abnormality of the heart, you will not be able to detect. And I want just in one slide concentrate here, because actually the message I want to pass is this, yeah? Those are not images in the first trimester, they're just example. But you have here hypoplastic left heart syndrome, tetralogy of Fallot, and transposition of great arteries. And we have in that data About this is not 95, 92, it's 95. 95% detection rate for hypoplastic left heart syndrome in the first trimester. About 38% detection of tetralogy of Fallot in the first trimester, and only 13% detection rate of transposition of great arteries in the first trimester. Don't you think that this is weird? You can answer. That was a real question. Like, don't you feel this is weird? No. No, you don't. Okay. Have you ever seen a hypoplastic left heart in the first trimester?
It's late even. Late after aortic stenosis, maybe later on.
Yes. So in the first trimester, what do you see? A disproportion. You can have a hypoplastic left heart in the first trimester, but it's rare. Usually what you see in the first trimester, it's a disproportion, right? You look at the heart, there is a disproportion. Yeah? So one would think that it's much less likely that you detect a hypoplastic left heart syndrome in the first trimester than a transposition of great arteries, because the transposition is already there. So why do you think that we detect much more in that data? There was much more detection of hypoplastic left heart syndrome than transposition of great arteries. Because we are used to look at the four chambers view. We do tricuspid, isn't it? So we were very used to the four chamber view structure, the normal heart. And a minor change in the normal structure of the heart, you will detect. But when it comes to the outflow tracts and the three-vessel view, they are not usually, maybe in some centers, but they are not usually part of our routine assessment, are they? You can actually look. Sometimes because it's just a sweep towards the fetal neck and you see outflow tracts and three-vessel. But in many centers, they are not really part of your assessment. And we have seen many pictures of four-chamber view, but you see much less pictures. You are exposed much less to the information of the normal outflow tracts and the three-vessel view. So therefore, that normality, that the normal anatomy, we are less familiar. You can, and this is probably the reason why we see less. Transposition of great arteries is already there in the first trimester. Tetralogy, you can argue that you can have a normal pulmonary artery, but although the VSD is there and the overriding aorta is also there, but you can argue. But the transposition is already there. But you only detect that in the outflow tracts in the three-vessel view. If you are less used to look into that, you will be able. You are less likely to detect the abnormality. So what I want to say here is that the more we do, the more we will be able to see. And it's very likely that if we can detect 90% of abnormality, it shows very little in the first trimester, we are very likely to detect much more of this other structure. And just for give you a little bit of the taste that will come up later on at 3:55, I think it's a very specific time, 3:55. With a continuation, which Professor Monique will show us a lot of cardiac abnormalities, just to show you the proof that we can actually see. This is a first trimester heart. This is late first trimester, 13 plus. Transabdominal scan. Yeah. Most of the scans they do is transabdominal. You use transvaginal very rarely. You can see very clearly. I just use that just to prove my point. So let me go there with my. So we can go back here. So we look at the fourth chamber here. Yeah. It looks more or less, that is bad, isn't it? Not good for you. Okay. You can see there, that is a fourth chamber that it could pass more or less as a normal fourth chamber. But then you go to the outflow tracts, it's already funny, and the three-vessel is completely abnormal. You just see one big vessel there, yeah? The color will help us. I used there the SMI. Sorry, I didn't put the information on the color Doppler. And the SMI is very nice to show you that. Let me just pause here. Oh, sorry. Go back. It's not easy to look from here. Okay, there we are. So when you use the SMI there, you can see that you have a nice interventricular septum there. And then left is left and right is right here. Sorry, I forgot to put the letters there. So there's no problem with the laterality. And then we see that the first vessel that comes from the left ventricle there, it comes out and bends and curves soon after. Aorta doesn't do that. And more important, if you see there, it also branches there, right? You can see the branches there. So that's a transposition, and of course it's late first trimester, but it's first trimester. And then when you go to the left, to the right side, you just have one big vessel that doesn't branch there. Yeah? See the one big vessel that doesn't branch. That's a transposition. And what about this one? Yeah? This is, you see? You see a four-chamber view that doesn't look good? Does it look good or not? From the image perspective, it's nice, isn't it? But from the function of the heart, doesn't look great. So you see all the widening of the myocardium and the big disproportion. Do you believe that this will evolve as a hypoplastic left heart? Yeah. Yeah. The image here you see when you have the color that tells you what it is. You can see here, yeah. Yeah, there is here. That's the pulmonary artery, and this is the aorta. You can see that there is a retrograde flow through the aorta. Yeah. So it is a good image. So I just wanted to share with this, and we're going to move on the live scan, which I'm not a big fan of live scan. We will discuss this later. So the challenge that we have in the first trimester, they are common to any gestational age. So we shouldn't be worried about that, because the heart looks better in the second trimester compared to the first trimester, but we will also look better in the third compared to the second, or after birth compared to the third. So they are challenges that are always there. Yeah? We already perform a scan at 11 to 13 weeks. We might use that time and also look at the heart properly, because we will be able to detect a lot of major cardiac abnormalities. As I will show you the data, and as Professor Monique will show you later on, all the cases of major cardiac abnormalities. We already know how to look into the heart, because most of you perform tricuspid regurgitation assessment. And if you know the four chambers, 90% of your cardiac assessment is done, because the rest is just a sweep towards the fetal neck. And I will show you that in the practical if the baby behaves and we manage to do that. But most likely the baby will not behave, and I will not be able to show that. But let's try, let's pray, let's hope for the best. And if you do that and you manage to see an abnormal heart, you have a lot of time to do all the studies that you need to do. And if you live in a huge country like Brazil, I'm originally from Brazil. I live in Portugal, but I'm originally from Brazil. Like Brazil, that you need to refer long distance to centers, so you have time to do that properly. And with that, I thank you for your time. I don't know.
We will wait a second. Jader, do you have your microphone on?
I hope, yes. Do you hear me?
Yes, I hear you very well. I have an additional question for you.
Be kind.
You stated that left hypoplastic heart syndrome was recognized so often.
Yes.
What I see in daily clinic is that people also call univentricular hearts quite often left hypoplastic heart if they just see one ventricle. Maybe in the data that you showed, could there be some misinterpretation?
In the data in the paper they say that those cases were classified separately. So that's why I believe that it's mainly disproportion that they saw.
Yeah, but did they do post-mortem examinations?
It's not clear there.
No. So that is, I think, still something that a lot of first trimester studies lack, is a good post-mortem examination.
Yeah, it is true.
So I think the baby's still in a quite good position.
Let's hope the baby stays there in a
The spine is down. We see a nice profile. And I want to invite the people here in the room also to ask questions. So if you raise your hand, I will come to you, and we will try to answer your questions or to show you what you want to see in this very tiny fetus of 12.5 weeks.
So shall we try to look at the heart here, Monique?
Yes, I would, that is the subject of your talk, Jano, so please
Well,
go ahead.
you see, that's I usually don't like live scans because they are real life, isn't it? The babies never behave in our
But we
behavioral
are
life.
not in a hurry, Jano, we are not in a hurry.
Okay, that's fine. Because the baby just changed completely.
So there we see the heart.
So I'm going to zoom in.
Yes,
There you can.
if I do teaching, Jano, I always say use your Cineloop. And in my department, they sometimes call me Monique Cineloop Haag. So,
Yeah, I like it very much as well because then, especially when I see something that because you see for a fraction of a second, isn't it?
Yes, now you're in a good four-chamber view.
Yeah, hopefully let's stay like this.
So the first thing in the four-chamber view is to assess laterality, to see if right is right and left is left. And I think it's quite nicely visible in this scan. So this side is the side of the stomach, and Jader already assessed probably that that is the left side of the fetus as well.
It is, it is.
So far you can say that the heart is pointing towards the same side of the stomach, so that is good. And only the one that performs the scan knows that that is left.
So I could be lying to you, isn't it?
People in the room say the septum is not clear, Jader.
So what should I do?
Improve your image.
The way I am. So this is a very nice comment actually, because we know that when we are very apical, we have the drop off in the second trimester, and because in the first trimester the interventricular septum is very thin, so it's you see very little if you are very apical. So you need to move to a more than 45 degrees. If the baby stops now, we'll be able to do that. Then you can actually see the interventricular septum better.
I think what is also quite good visible is that in the first trimester the baby moves a lot, and I see behavior of Jader which I like very much and which I think is a great opportunity to teach you all, that the baby moves so much. Don't try to chase the baby. So what I mean by that is don't move the probe within the movements of the baby. Just keep the probe where you are, because you are in a nice position for the right for the four-chamber view. And if the baby moves, then usually it moves back into that plane. And if you continuously try to follow the baby, the scan gets very unquiet, and the baby moves even more. So don't move the probe too much, I would advise. Jader, are you agreeing with
I
me?
agree, yes. You get one of the things that I tell my fellows when they are learning is exactly that. Don't move too much, I get dizzy and then I don't... Looks like you have some spastic movements.
You are a little bit different teacher than I am.
Yeah, I'm not...
If you say to your students that you go...
I do tell them, yeah. They
Now
go
maybe we could use some
Color.
SMI to...
yeah, let's go for SMI, now that the baby decided to not do any of the things that I want. So, SMI... Sorry, let's...
So the comment of the ventricular septum was a good comment, and for that, these kind of modern techniques really help you. Although I'm reluctant to say that you can rule out small VSDs at this early gestational age. I think that should not be the aim of your investigation at 13 weeks, to detect small muscular ventricular septum defects. Jader, as soon as you disagree with me, then
No, I
please
agree with
comment,
you. I agree very much with you.
because it's now your session.
No, but that I was looking at here, I agree with you very much. That's not the case. I mean, not to rule out small VSDs and this kind of thing, no. The main use for the SMI to me is that you can see very clearly the connection between the vessels and the ventricles, especially here. We'll try to improve a little bit the image here with the positioning.
And remember, at 12 weeks is very, very small and very, very early. This is a nice depiction of the ascending aorta from the left ventricle.
With a nice septum there, as far as we can say, and then try to see and try to show you there. You see there? Do you like Monique, the image?
I like it very much.
Okay, thank you. We didn't. And then we move to the outflow tract here, to the left, to the right one, from the left to the right one. Although it's not great here, try to. We can sort of see here the branching of the pulmonary artery. You can actually see very often the two branching there, the pulmonary artery there. Yeah, that's
There it comes.
the duct. Yeah. And there you go. Then we have the three vessels right there as well, where you can actually see the superior vena cava separated from the aorta. Because a lot of the times when we're using normal color Doppler, even the high definition one, either doesn't paint very well the superior vena cava, or you have overflow between the superior vena cava and the aorta, and then you get only one image.
I think those two modalities are very nice to compare to each other.
Yes. There you have the pulmonary artery there, with the branching of the pulmonary artery. Quite
This
nice.
is a great picture.
Yeah.
Now, can I ask, sorry, is the SMI unique to Canon, or does the volume sign have it as well?
You will have different names. I don't know if the background of the technology is similar, but you may have different names of the technology.
Volume sign has it as well.
I mean, the techniques are all quite similar, let's say, but differences are in possibly the resolution or the frame rate or the noise reduction. So this one, for example, has 55 frames per second, so it's pretty fast.
Well, yeah, the frames per second will affect directly your ability to look at the heart.
And that is something people don't often look to and don't adjust their machines to. In my presentation in this afternoon, I have one slide with some tips and tricks how to adjust your machine to the first trimester. Because I often see people scan at 13 weeks with, for instance, PRFs at 50 centimeters per second, and that is not the way that you can depict slow velocities, because the lot velocities in the first trimester are far more lower. Not in the ventricles, but they are in the outflow tracts and especially in the pulmonary artery branches.
Monique, can I just show something here?
Yes.
I don't know if you can see the caliper there. Can you see the caliper?
Yeah, you can see the caliper very nicely. We see the crux.
Yeah, we see a nice crux. And you can even see the valve, the AV valves there. You see where they are? You see the offset
Yes.
of the valve? Of course, that's not the point of using SMI, but when you have a very nice position and you have a good image, you can actually see that as well. And if we go back here, we go back to the outflow tract, which is for me the greatest advantage of the SMI there. Sorry, let me just go back here. Three vessels, there. The image that we were showing before, well, that's slightly better there. The connection of the aorta with the
Can you try to depict the pulmonary veins, Jader?
yeah, let's go for the pulmonary veins then.
Because yes, it is possible. I don't know if it's possible in this fetus, but I already
Yeah,
saw it several times in the first trimester.
let me see if you can go.
It's getting in a better position.
For the septum, definitely look there. Are you happy with the septum? I don't know who said that the septum was good. Are you happy
Oh, yes.
now?
Are you happy with the septum
No,
now?
no. Okay, good.
Yes, everybody agrees.
So let's
and
try.
also in the B image, the aortic annulus is far better visible.
I think we will have some difficulty here looking at that. Let me just try to that way not. maybe here we will lose a little bit of the definition there for the rest of the heart, but that definitely you can see there the little bit of the PA.
What you have to realize is, of course, that this technique is direction independent. So you cannot see the direction of the blood flow. There you need the other color Doppler. Maybe you can compare it because possibly it is visible with AEDF as well.
Let me try. It becomes
now you have to turn down your PRF, but also you should turn down the color gain a bit.
There you have one at least, you can see, and the filter is too.
Maybe 12.5 weeks is
a little bit. Sometimes we can see. I see one there that shows up every now and then. The other one.
That's one.
Yeah.
But this we have to realize. The hearts at 12 weeks are really, really small, and an additional scan at mid-pregnancy is really necessary to rule out everything. You cannot see everything at 12.5 weeks.
I don't know if
you see it's 7 millimeters, the total length of the heart. You see the calipers in the
7 by 4, so it's really
left
tiny.
bottom.
So we can try to move to some sagittal views because I didn't show. So let me just put here again the presets. There. Let's see the arch. You can also use the color.
I think this is ductal arch, isn't it?
This is ductal arch, yes. They are sort of one on top of the other.
I find this quite difficult in first trimester to really distinguish between to get.
They are much more close.
Exactly, they are so close that it is difficult to have two separate pictures of each arch.
You can see the systemic pain.
And because the flow is also far more lower, color in the transfers in the horizontal direction is always difficult, of course. That's inherent of in the technique. But in first trimester, because the flow is lower, slower, that's even more difficult. So the first ascending aorta is not coming up yet.
Is there anything that someone from the audience would like to?
Other questions?
In your clinical practice, thank you so much. In your clinical practice, how long do you allow for your examinations for dedicated time for a complete exam?
Jader, the question is,
Yes.
how long, what is your time slot for a dedicated, I think a full first trimester scan, not only the heart, a full first trimester scan, including the heart.
Okay, we have because we are so we are a training center as well. So we have 45 minutes for the first trimester scan. Okay, because the younger doctors scan with the seniors, then the seniors take over. But we have 45 minutes for the whole scan.
And if you are a senior scanner, what do you think the time slot?
Usually, on average, because the first 15 minutes is for the junior, then the other half an hour is for the senior.
Yeah, I fully agree with you. I think half an hour is, if you are a little bit experienced, half an hour is enough.
And do you have a certain time that you run the color adapter to minimize the thermal exposure to the
Yes,
we keep it as low as you need. You don't really, because what you need from the color Doppler, as we're doing here, for example, I have the heart, I've seen the 4-chamber, the outflow tracts and the 3 vessels, and then I go again with the color, and I see again. In a normal routine, that's the time that takes, if the baby's in a good position, right?
I think that is an important question. That's the question on safety. I think one should not use color Doppler, but also no pulse Doppler under 10 weeks. If there is not a really a question, and just to let the mother hear the heartbeat is, in my humble opinion, not scanning according to the ALARA principle. So I would say don't do that, because in that particular period, especially 5, 6, 7, 8 weeks, the heart is still developing and still not finished. The valves have to be formed, so don't do that. Especially pulse wave Doppler will generate warmth at the level where the caliper is. But I think after, let's say, 11.5, 12 weeks, there is no real harm expected anymore. The baby is much more larger, but still only use it where you need it for and keep it as short as possible. And the time frames that you need are really quite short. It's only a few seconds.
Yeah. I
Other
agree.
questions? Everybody's very impressed, Jader.
Oh, thank you very much. You are kind. You are very kind. Okay, so
Other measurements maybe? Somebody interested in measurements?
the
Do
measurements.
you measure tricuspid and mitral pulse?
No, well,
Doppler?
not in the routine. We do
Not in
tricuspid
the
flow
routine.
or routine, but we don't do.
And do you measure the cellular pulse?
No, in the first trimester. No.
Peak systolic velocities?
We try to keep the first trimester the most, so the aim, let me just do something. Do you mind if I go there with you? Do you want to see something more in the scan? No, you're happy with the scan? Okay, so I will go there. Thank you very much.